Thank you so much to the organizers for giving me the chance to share our study with you and some of the work that we've been doing looking at cannabis. And wasn't sure if I was going to do this or not, but it's a small known fact that j'ai fait mon premier postdoc à Paris, mais mon français est très mal, donc après en anglais. So that's pretty much all the French that I know, so voila. So we've been over a lot of this, and I don't think I need to share with the audience at all why we're doing this work. I think it's very clear that everyone here knows the importance of doing work among HIV-infected individuals because it is a global epidemic, and we still have not found a cure or any preventative measures. And I think that I'd like to start just with a very broad overview. And it's been almost 4 decades since the advent of the AIDS epidemic, and I think even now today we're still at a place where the glass is half full and half empty. So on the half full side, we know that HIV is the cause of AIDS, so we have defined the etiologic agent. We have really great lab tests now that can help us to monitor and prevent the infection. We know where it comes from and how the epidemic started, and we do have a lot of really potent anti-HIV drugs that can be used to control the infection in people who are infected. But on the glass half empty side, there is an absence of a vaccine or a long-lasting microbicide that can prevent infection. We don't have a treatment that can eradicate infection once someone is infected. And we have an incomplete understanding of the pathogenesis of infection. And so our lab is really interested in exploring HIV pathogenesis and how it contributes to disease progression. And as was introduced, I specialize in mucosal immunology and looking at the gastrointestinal tract and how what happens in the gut could be really influencing HIV pathogenesis. So to just get everyone on the same side, what I'm showing here is a overview of what we think happens in the gut during HIV pathogenesis. So we have I did that wrong. Go back. Here we go. On the left here is a healthy gut. So you can see that we have a nice tight epithelial barrier. And in the lamina propria side, we have homeostatic cells and cytokines that populate this tissue. And on the other side, in the lumen, we have a healthy microbiome. However, in the context of HIV infection, we know that there's breakdown of the epithelial barrier, as well as increased frequencies of pro-inflammatory cells and cytokines in the lamina propria, as well as an altered microbiome on the other side in the lumen of the gut. And what could happen here is, and several studies have shown this, is that all of these disruptions in the gut probably contribute to systemic inflammation in HIV-infected individuals. So what is systemic inflammation? It's systemic inflammation or immune activation in HIV-infected individuals is described as polyclonal B cell activation, increased T cell turnover, frequencies of activated higher frequencies of activated T cells, and higher serum levels of pro-inflammatory cytokines and chemokines. And so all of this probably contributes to HIV pathogenesis and increased rates of HIV pathogenesis. But why do we care about that? So what I'm showing here is just a very broad overview. I'm sure everyone is familiar with this, and it's the clinical characteristics of HIV infection. So you can see that in acute infection, there's significant loss of CD4 T cells in the blood and in the gut, as well as really high viral loads. And then once an individual reaches chronic infection, the viral loads kind of plateau out, but the PBMC CD4 and the gut CD4 continue to be depressed as compared to what you would have seen in an uninfected individual or prior to infection. And actually, if we look at systemic immune activation, it's probably a better predictor of disease progression than even viral load CD4 in either the blood or in the gut. And in addition to being a predictor of disease progression, several studies have also shown that chronic inflammation and immune activation is also associated with increased risk of morbidities and mortality in HIV infection. So it's really important that we understand how increased inflammation and immune activation is occurring and figuring out ways that we can limit it so that we can limit either disease progression or morbidity and mortality. As I mentioned before, we do have a lot of antiretrovirals and really good drugs that are able to suppress viral load in infected individuals. And in addition to that, there are other benefits like reduced risk of drug resistance, better overall health, improved quality of life, and decreased risk of HIV transmission. But even in the context of successful antiretroviral therapy, most HIV-infected individuals will still have a higher level of inflammation as compared to an uninfected individual. So just to kind of bring all this background together, really what we're finding is that in the context of HIV infection, we do see that there's this vicious cycle of infection of target cells, CD4 depletion in the gut, microbial translocation, and higher inflammation, and it can lead to increased AIDS and non-AIDS morbidity and mortality. And with antiretrovirals, we can really suppress a lot of these negative outcomes. And so what we're really interested now in is exploring how cannabis could be a part of this and how we might be able to use cannabis in order to further decrease a lot of the negative impacts that we see from HIV infection that can't be corrected just using antiretroviral therapy. So one of the benefits of being one of the last speakers is that a lot of the background has already been gone over by the previous speakers. So I'm going to really try to get quickly through my next background slide so we can get to some of the work that I've been doing. This slide was, or this figure shows the rates of cannabis use within the HIV-infected community, and we do know from what the previous speakers had said is that it is quite disproportionately high as compared to the uninfected population. And as Dr. Mahesh showed earlier in his talk, we can see that there have been non-human primate studies that have shown that administration of cannabinoids can actually slow progression of SIV in the monkey model. Also, in a human setting, we know that there have been previous studies that showed that people who regularly use cannabis have lower viral load after seroconversion to HIV infection as compared to people who don't use cannabis daily. So a lot of this is all kind of coming together to show that potentially there could be a beneficial impact of the cannabinoids. And again, going back to our interest in inflammation and immune activation, we know that cannabis has been shown to be beneficial in reducing inflammation, and there are probably biological reasons for this. So we wanted to take all of that and really examine in a human population what could be happening in terms of HIV infection and use of cannabis. And so we hypothesized that HIV-infected individuals who use cannabis would have reduced indicators of inflammation and immune activation. In order to examine this, we did a retrospective study. We worked with Dr. Peter Hunt at UCSF and got samples from the SCOPE study there. We got both plasma and peripheral blood mononuclear cells, or PBMCs, from individuals who reported that they regularly used cannabis and people who reported that they never used cannabis. And I'll talk a little bit more about the usage and self-reporting in a second. From these samples, we did a couple different things. We looked at cannabis metabolites in the plasma. We did a Luminex assay for inflammatory markers. We looked at some markers of microbial translocation and mucosal barrier dysfunction. And then a lot of the data that I'm going to be showing you is from our studies looking at the PBMCs and cell frequency, phenotype, and function. As I mentioned, one of the things that we did is look at cannabis metabolites in the plasma. The previous speakers have noted that it's quite difficult when you look at someone who, or when you're assessing a population and you have different ways to identify usage of cannabis, or what constitutes a heavy user or a moderate user, and also how do we really how can we really tell from self-reports what that means. And so one of the first things that we did was we used mass spec to quantify the levels of different metabolites in the plasma of these infected individuals. And so we looked at THC, carboxy-THC, 11-hydroxy-THC, and THC, or carboxy-THC glucuronide. And this was in a collaboration with Dr. Nina Saharanen at the University of Washington. And what we can see is that the way that this is divided up is the people who self-identified as being a non-cannabis user or a cannabis user. And we can see that at least for THC, it's quite clear that they are, the people that said they were cannabis users definitely have cannabis in their system, and most of the people who said they weren't cannabis users did not. However, when we start, and it's been noted that THC does have a very quick half-life. So one of the reasons we looked at these other metabolites is to see whether or not things that last a little bit longer could indicate someone who may have been exposed previously. And so what these red dots are indicating are people that had in their system cannabinoids or not. And we used this as basically as an exclusion criteria. So we were able to say, if you said you were a non-cannabis user, but you clearly have cannabis in your system, we're going to take you out of that group and exclude you from the analysis so that we have really robust data. And we used we combined the data from all of these to basically identify people who may not have fit as well into their groups as they could have. So in this way, we're able to really ensure that we have well-defined groups. And as I mentioned, THC itself has a very quick half-life, at least in the blood. And so one of the things that we wanted to do is really determine within the cannabis using group, how can we identify the heavy users from the non-heavy users, from the occasional users, and that type of thing. And so what we did was we focused on this metabolite here, the carboxy-THC. And the reason that we looked at that is because several other papers have tried to use carboxy-THC as a way to identify occasional versus heavy users, especially in the setting of driving impairment. And so we focused on some of the definitions that previous papers had used in terms of a blood metabolite level to identify these individuals. And so we stratified among the people who we confirmed were cannabis users and that had detectable levels of the carboxy-THC. We identified heavy cannabis users, moderate cannabis users, and then occasional users. We only had 3 individuals that really fell into this group of an occasional user. So for the purposes of really assessing in this population, we didn't consider those patients anymore because we just would not have reached statistical significance with only 3 individuals. So all the data I'm going to show you is just focusing on the moderate and the heavy using group. So one of the first things that we wanted to look at was CD4 T cells, because as we are HIV researchers, we wanted to understand how cannabis could be affecting the CD4 population in these individuals versus non-cannabis using individuals. And I should mention, all of these individuals were on antiretroviral therapy and had suppressed viral loads for at least 2 years before we included them in the study. So this is a suppressed population that we're looking at. And what we can see here, again, this is using our flow cytometry data. So on the left is just some representative gating showing CD4 and CD8 T cells. And we can see that among the cannabis using group, either the moderate or the heavy, there's no significant difference in terms of the frequency of CD4 cells compared to non-cannabis users. And we see the same thing with the CD8 T cells. However, when we look within the CD4 and CD8 T cell population, and we look at expression of HLA-DR and CD38, which classically is a way to identify activated T cells, especially in HIV infection, we can see that there's a significant reduction in the frequency of these activated T cells in the heavy cannabis using group as compared to the non-cannabis using group. And this is true for both CD4 cells and CD8 cells. So that was really exciting to us because it indicated that perhaps, yes, cannabis use and regular daily cannabis use is associated with a reduction in immune activation, at least in the CD4 T cell and CD8 T cell population. We also looked at B cells. So we identified B cells based off of CD20 and HLA-DR expression. And we did the same scheme where we looked at heavy and moderate users compared to cannabis users and didn't see a difference in the frequency, total overall frequency of B cells in these cannabis using individuals versus non-cannabis users. But again, when we drill down and we look within the B cell population, we can see that there's a significant a significant increase in the frequency of IgA expressing B cells in the heavy using group as compared to the non-cannabis using group. And there's also a significant reduction in the number or the frequency of B cells that are expressing TNF-alpha, which is a pro-inflammatory cytokine, as compared to non-cannabis users. So again, what this indicated is that cannabis really could have an immunological impact in these cannabis users as compared to the non-cannabis users. We also looked at monocytes. So this is my personal favorite cell type in all of the immune cell types that we have in the body. I am a monocyte girl. And what we found when we looked at the monocytes is actually that, so I'll walk you through this. Among total monocytes, we have a few different subtypes. So we have the CD14 high expressing classical monocytes, which are typically anti-inflammatory monocytes. So they express a lot of IL-10, other anti-inflammatory cytokines. We also have intermediate monocytes, which are CD14 high, CD16 expressing, and non-classical monocytes or trafficking monocytes, which are CD14 positive and CD16 positive as well. And what we can see is that the classical monocytes in the heavy using group are actually significantly higher than in the non-cannabis users. And there's a significant reduction in the intermediate and non-classical monocytes, which are the more pro-inflammatory producing cytokine monocyte populations. There's a reduction of those in the cannabis using groups as compared to the non-cannabis using group. Again, kind of really supporting our hypothesis that cannabis use could have an immune impact and reduce inflammation and immune activation of immune cells in these HIV-infected individuals. We also looked at dendritic cells. So we looked at two different types of dendritic cells, the myeloid dendritic cells and plasmacytoid dendritic cells. And we did see that there was a significant reduction in the frequency of myeloid dendritic cells in both actually the moderate and the heavy using group as compared to the non-cannabis users, but really no impact in the plasmacytoid dendritic cells in the between the three groups that we were looking at. We also looked at, among these antigen-presenting cells, which are what dendritic cells are, we looked at cytokine expression in order to get a really functional outlook on what these cells could be doing. And what we find is that there are definitely significant impacts of the cannabis use, because we see that there are lower frequencies of IL-23 producing antigen-presenting cells, TNF-alpha producing antigen-presenting cells, and IL-10 as well. And IL-23 and TNF-alpha are both, as I've mentioned, pro-inflammatory cytokines. So looking at this reduction of pro-inflammatory cytokines within these populations really, again, supports our hypothesis here. And finally, I mentioned that we looked at levels of markers of microbial translocation and barrier integrity. And so we looked at LPS, which is lipopolysaccharide. It's a component of bacterial cell walls. We also looked at LBP, which is lipopolysaccharide binding protein, which along with soluble CD14 helps to bind LPS. We also looked at IFAB-P and zonulin, and we didn't see any statistical differences between the three groups that we looked at here in terms of these markers of microbial translocation or barrier integrity. But to me, what that indicates is that we're not hurting anything, right? Like there is no negative impact of cannabis where we're seeing that your microbial translocation increases in these infected individuals. So just to summarize what I've shown you so far, in this retrospective study, we looked in the periphery of HIV-infected individuals, and we found that heavy cannabis use is defined by plasma metabolites. We see that there are lower frequencies of activated CD4 and CD8 T cells. There is increased IgA expressing B cells and decreased TNF-alpha expressing B cells. Lower frequencies of inflammatory antigen presenting cells, including intermediate and non-classical monocytes and MDCs, as well as altered antigen presenting cell cytokine production. And at least in this cohort, we didn't see any alterations in the expression of plasma markers of inflammation and microbial translocation. So what I'm going to show you now is kind of a continuation of this work. We have a graduate student in the lab named Ryan Chu, who's been kind of spearheading a prospective study that we're doing in order to not just look in the periphery, but to look in the in the mucosa, because primarily we're interested in what happens in the mucosal tissue of infected individuals. And so we're doing similar assays where we're looking at drug level quantification by mass spec, inflammation by multiplex and ELISA, but we're also, in addition to plasma and peripheral blood, getting colon biopsies so that we can specifically look in the gut of HIV-infected individuals who do or do not use cannabis and look at things like inflammation and immune function, the viral reservoir, do specific drug level quantification in biopsies. We'll also be able to, we've also been collecting urine and stool, so we can look again at drug level quantification, so do pharmacokinetic analysis in the urine, look at the stool for different metabolites that could be interesting and indicate bacterial function, as well as again looking in the periphery for inflammation or immune activation markers, viral reservoir, etc. And so I'm going to share with you some preliminary data from this work. It's not complete in any way. We have a long way to go for this work, but I think that what we are seeing so far is pretty exciting. So this is just starting very basic, looking at CD4 and CD8 T cells. This is looking not just among, this is for HLA-DR and CD38 expressing CD4 cells as well as CD8 cells in the PBMCs and in the colon. And what we can see in the PBMCs is that it's definitely recapitulating what we saw in our retrospective study using cryopreserved cells, in that we see lower frequencies of activated CD4 and CD8 T cells. But when we look in the colon, we're also seeing that there's reduction of inflammatory or immune-activated CD4 and CD8 T cells as compared to non-cannabis users. And I do just want to mention, we have done the mass spec on some of these, and what we are, in order to do drug level quantification, and all of these cannabis users that are in the red here do fall within that heavy using group, at least by the definitions that we've used in the past. We've also, or Ryan has also looked at B cells, and so he is also seeing what we saw in the periphery, where we see increased frequencies of IgA expressing B cells and a decreased frequency of TNF alpha expressing B cells. But he's also seeing an increase in the IgA expressing B cells as well, again in the periphery, and we see the same types of responses in the colon. And I think what this indicates, at least in this preliminary analysis, is that there definitely seems to be an impact of cannabis on a B cell phenotype or function level. One of the other things that Ryan has been looking at is short-chain fatty acids. So short-chain fatty acids are produced from when bacteria ferment fiber, and they're very important in terms of signaling in the gut, and they perform functions that communicate with colonocytes. Three of the most important short-chain fatty acids are acetate, propionate, and butyrate. And the reason that we're interested in these is that there have been studies, and especially one in an HIV-infected population, that showed that when you have loss of bacteria that can produce butyrate in HIV-infected individuals, it's associated with increased microbial translocation and immune activation. So the idea here is that when you have microbial dysbiosis and you lose these good bacteria, you are reducing their ability to produce things that have a beneficial impact on the host. And so we were interested to look at short-chain fatty acid production within this HIV-infected population that do not use cannabis. And what Ryan has been able to show, at least in the preliminary patients that we've gotten, is that cannabis use is associated with increased levels of these three main short-chain fatty acids. And this is from the stool of the patients. And so we're following up on this analysis. We actually just finished extracting all of the DNA from the stool samples, so we'll also be able to do the 16S sequencing to look and see whether or not cannabis use is changing the microbial populations within this cohort that we're looking at, and whether or not that would reflect the changes that we see potentially in short-chain fatty acid production. So to sum up, similar to our previous findings, we have been able to see that HIV-infected individuals who regularly use cannabis have decreased frequencies of activated CD4 and CD8 T cells, not just in the periphery, but in the colon as well. We have increased frequencies of IgA and IgG expressing B cells and decreased frequencies of TNF alpha producing B cells, and elevated levels of short-chain fatty acids, including acetate, propionate, and butyrate. And so I'd just like to leave you with a couple of take-home messages. I know I went over a lot of really hardcore immunology, which is the world I like to live in, but I know not everyone likes to live there. So these are, if you take nothing else away, I hope I can leave you with these thoughts that heavy cannabis use can be associated with a potential beneficial reduction in systemic and mucosal inflammation. It can also impact microbial function, including short-chain fatty acid production, and potentially we could explore non-psychoactive cannabis derivatives as novel anti-inflammatory strategies to be used in conjunction with antiretroviral therapy. There's a lot of people that put a lot of work into this. I'd just like to thank my lab, my mentor, Nicole Klatt. I did my second non-French speaking postdoc with her, and she's still my mentor, and all of the people in our lab. Nina Isaharanen's lab did the mass spec analysis. Peter Hunt provided samples. Our prospective studies are headed up by Ann Collier at the ACTU and the University of Washington. our funding sources, and of course everyone who participated. So thank you.